Welcome to the Expert Podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Beginning here, I will show some of the differences. For example, AML is more common in a very young age than adolescents and young adults, so it starts to increase later and then becomes very common after 60. Adult AML has less cytogenetic abnormalities than in pediatrics. Pediatrics tend to have more good risk cytogenetics, less mutations burden, and there are some subsets of AML that is exclusively from pediatrics. Many of the myeloid leukemias in kids have also lymphoid markers. So this also gives an idea of the cytogenetics and molecular changes of pediatric versus adult AML. Here showing that the normal karyotype is less common, increase in adult. This is the most common type of cytogenetic abnormality in children below 2 years of age, the KM22A abnormality, and the RUNX1 is more common in pediatrics between ages of 2 to 15. And this here exemplify one type of leukemia that is exclusive of pediatrics. Still very aggressive type of leukemia, as the CBF-A23A GLIS. Most of these cases are megakaryoblast leukemia, and that is not essentially found beyond 3 years of age. This related to the most recent incidence rates, case distribution, and 5-year survival by age in the United States. I remember in your narrative, you said the survival of kids with AML is about 80%, and you may be right, but that is restricted to a very small number of patients. Typically, patients, when they are admitted to protocols and institutions, will not reflect well what occurs in real life or real world data, because many patients don't qualify for protocol treatment because they are too sick, or because complications of other nature. In the end, you don't capture a lot of kids who die. Here you can see that the survival in the United States, 5-year survival, published in 2003, is 68%. And also is the same for the group age 15-19. So we still, in the United States, as a population-based registry, capturing everyone less than 70%. And this is a reality in Central America. Just for example, how the mortality burden in AML depends where the patient is born. So we talk about a lot about prognostic factors, but actually one important prognostic factor in AML for the child is where the child is born. For the developed countries, we can say that 70 to 80% of the children with AML now survive. It also that intensifying conventional chemotherapy will not improve the results and may be associated with a long-term sequelae. Right now, hematopoietic stem cell is really very important, but we have to be concerned about the number 2 there. So the future, one, understand the mechanism of leukemia resistance. We still don't know why leukemia cells survive after a massive amount of chemotherapy. So we also have to determine the role of the new targeted drugs and how to integrate with conventional chemotherapy. Maybe the way that we're doing, put together very intensive chemotherapy with the target therapy together, may not be the best, because when we do this, we are asking the question if the combination is tolerable. We are not asking if it's efficacious. So I think we have these drugs that have a signal that may be efficacious, but we put together with conventional chemotherapy and the targeted drug would make my sense. We have to understand too the studies of immune cellular therapy, the CAR-Ts, and also improving risk stratification by incorporating next generation sequencing data. And for countries with limited resources, 34% of children now survive. Intense chemotherapy is associated with a very high early mortality, some places 40%. Transplant in these countries are still not available for the majority of patients, so we have to improve access. So we have to think of innovative ways of creating regional centers that could have capacity offering intensive chemotherapy and transplants, and improving risk classification by understanding which are really the essential elements that can tell the prognosis and develop those and not the entire genetic sequence, because it may be too costly for them. And coordinating efforts among centers treating the children with AML.